Hi, welcome. My name is Denise Smith, and I am here to provide about a 40-minute overdose response presentation to talk to you a little bit about the context of drug overdoses and overdose response and the drug landscape and how the drugs and the drug landscape impact overdose response, naloxone and how it works, and some myths and misinformation about what's going on in the drugs and the drug landscape, and then maybe how you can then take those myths and misinformation and kind of myth bust that in your communities. There's lots of QR codes and websites in this presentation as well, and so that you can dig deeper and then you can take that information back as well into that into your communities or into your presentations. If you've had overdose response or naloxone training before, some of this might be review, and I hope that you learn some new information. I think there will be new information here for you to learn, and if you haven't, welcome. I'm really glad that you're here. So you'll probably hear me say drug landscape and information and overdose a lot. And this is the first slide of that here. But in 2026, the drug landscape looks, new, and it does keep changing. A lot of the information that I get about Maine comes from a lot of different places, but in Maine, we get information from the state at mainedrugdata.org, and there is a QR code there at the bottom of your screen if you want to check and keep up with that information. Maine started tracking overdose and fatal and non-fatal overdose back in 2020, and you can continue to track that and see the historic information on mainedrugdata.org if you're interested in that kind of thing. And on that website, you can see county data and you can see state data. You can see lots of other demographics as well. You can see EMS information. You can see the types of drugs that are found in tox screens, age information. So there's a lot of information to be found if you're interested in seeing that, as well as the different, changes over the course of the years. So what we know from that is that the drug landscape is always changing. What we also know from mainedrugdata.org and other, sources is that there is an increase in sedatives in the landscape right now, and those sedatives are changing the way we respond to overdose response to overdoses, and I will address that over and over again in this presentation. What we also know, at least in Maine, and I'm sure this applies to across the country, across the world, is that most overdoses are accidental. And I think for me, that is one of the reasons why it's so important for me to communicate a lot of the information that I communicate. And it's incredibly important why people are here, is that we're here to save lives and you're here to save lives, and people don't want to die, and to reverse an overdose means that that person can live another day to move on to whatever that next step is for them, whether it's to find recovery and eventually, or to to live, to do whatever's next for them, and that depends on whatever that person wants to do. But whatever it is, they'll figure it out. And the important part is that they didn't die, and that's good enough for me. So as we know, and as most people know, the word fentanyl has become a word that most people who are involved in this work, or who are out there, have heard that word. Fentanyl is one of the drugs that are found in most illicit drugs and are involved in most overdose deaths. It is in a lot of the drug overdoses in Maine. One of the myths that are out there is that it does not respond to naloxone anymore, but it does. It is an opioid. It does respond to naloxone. There's no super fentanyl drug that no longer, supersedes the naloxone product. There's no naloxone resistant opioid out there. There's also, no way that someone can build up a resistance to naloxone. So if someone overdoses, 5 times in their life or whatever, then all of a sudden they're, super resistant to being to overdosing or to having naloxone reverse that sixth overdose. So that doesn't happen. There's no resistant or buildup of resistance to naloxone. So that doesn't happen either. Sometimes you might hear that kind of misinformation out there. You also can't overdose by touching fentanyl. And that is a myth that kind of ebbs and flows over the course of the years that I've been doing this. I've been doing this since 2020. So that has popped up over and over again. That's with the exception of children. And, people have, children are exposed to drugs. That has happened in Maine. They have died from exposure to drugs, and that is completely different than an adult that's responding to an overdose in a Good Samaritan situation. So that's completely different. But for an adult that's responding, you are safe to touch fentanyl without putting yourself in danger. And there are 2 QR codes there on the corner of the screen. One is about touch overdoses and all the research that has been, done on touch overdoses. So many different situations that a person can be put into about, being exposed to fentanyl in that way. And you can read all the research there. There's also a bunch of other myth busting things about fentanyl that you can read about in that, touch overdoses is one of them. There's some other things, the naloxone resistance, a bunch of other things that you can check out there as well. Another thing that can happen with fentanyl in a person's system is it can cause some muscle rigidity. And what that means is it can cause clenched fists. It can cause a locked jaw, and it can cause a hard, they call it wooden chest, but it can cause these the muscles in a person's abdomen and chest to get really hard and wooden. And that does impact overdose response. And I will address that as we move further through and get to the steps of overdose. Another myth that has come up over and over again, but that there is no data to support, is fentanyl-laced cannabis. And there's several, reasons there on the screen. One of the most, the biggest reason, I guess, is, or the major impact that you would see out in the wild is that overdose rates are dropping versus overdose rates increasing because of the number of people who use cannabis. You would not see an overdose rate dropping. You would see it increasing. So you can check out that QR code there for all that information. It goes into detail. And there's another bonus QR code there in the corner about cannabis use toolkit, talks about retail market cannabis versus the medical marijuana, medical grade cannabis, and the safety, the safety of adult retail market cannabis versus medical marijuana. So the other drug, the 2 sedatives right now that we've been hearing that are impacting overdose response that you'll hear us discuss as being a concern, drugs of concern, are xylazine and the second drug that I'll refer to here. Xylazine is the first one that's sort of moving out of the system, or out of the landscape, but still impacting people, and that is xylazine. And again, there is a QR code there that talks about it, but it is a sedative. It's a veterinary sedative. It's referred to as zombie dope because it makes people like zombies. Pretty literal there. It's added to fentanyl and other drugs, but it shows up in other drugs because fentanyl is typically added to other drugs. People don't typically use it alone. It causes very heavy sedation, so it makes people really, really sleepy. It impacts overdose response because it affects the appearance of an overdose and the way a reversal looks, because people are just so sedated from the drug. With xylazine, it causes really severe skin wounds, and these skin wounds can happen not necessarily at the site of an injection site. You don't even have to be using IV drugs in order to get these skin wounds. So if people are using fentanyl in other ways, and there's xylazine in those drugs, then you can get these skin wounds. And these skin wounds are really severe. They can be really severe. They also are very treatable if they are treated. So if not treated, they can lead to amputation. If they are treated, then they can be treated. So you can also look up the skin wounds online. You can Google them and see the severity of these wounds if they aren't treated. And they, again, are very, very severe, deep necrotic skin wounds that go right down to the bone. And the good news of xylazine is, number one, it's sort of moving through the system, with as it became aware of xylazine, of course, then came regulation. And so it started to move out of the system. The bad news is that it gets replaced with other drugs, which I'll, move to the next slide there, to talk about the drug that's replacing it. But it's still out there. So, and the other thing about that is that, medical professionals know how to treat those wounds now. So as we became more aware of the xylazine in the drug supply, then the medical professionals became aware of how to treat it. So medetomidine is the drug that's replacing the xylazine drug, which we know is much more potent. Drug users are becoming aware of medetomidine. There's a QR code there about it as well. Again, replacing xylazine, much more potent, much more complicated because of the issues that causes. So it can cause some blood pressure issues. It complicates withdrawal because it can create some major withdrawal effects after the fact. So it's really important that we focus on getting EMS on the scene for medetomidine. The other thing is that these drugs are not, these are not opioids. However, we should still give, naloxone at the scene, which I will again address later. But it's added to fentanyl, but it's not an opioid. It does cause heavy sedation, not taken alone. It's added to fentanyl and other drugs because it's found in other drugs, but only because fentanyl is found in other drugs. Again, impacts the appearance of overdose response because it creates this really sedative, sedated effect on a person. Again, medical professionals are becoming aware of how to treat medetomidine, but it's really important that EMS or people are taken to medical professionals so that it can be treated, and it can involve the need to be in the hospital or need to be in ICU. So moving on to naloxone. Naloxone is 100% safe. So there's lots. So naloxone, formerly known as Narcan. So Narcan, it's now available over the counter. So naloxone is the generic name. It was a branded, medicine that was only held by one pharmaceutical company, and now it's naloxone. You can buy it over the counter. So you can see a couple of different versions of it there. Naloxone, you can see the Walgreens version. This was the, branded version, Narcan. This is what we get now. We get it from Piscataquis, which is naloxone. This was the prescription version. This is the over-the-counter version of the Narcan that we used to get. That's a 4 milligram version. There's lots of different versions of naloxone now that you can buy. There's a lot of types. There's a 3 milligram version of naloxone called Revive, which works just as well with fewer side effects for a drug user. So you can look at the QR code there on the side of the screen with the different types of naloxone that you can check out and learn about as well. And that's really good to have that sort of information. So the way that naloxone works is that it knocks the opioid off the brain receptor for 30 to 90 minutes. So it knocks and blocks it for 30 to 90 minutes. It does not work instantly. So when you see someone on TV get a spray of naloxone in their nose, and that person wake up instantly, that is not real. That's not the way it works. So it's really important to recognize that like that's just poetic license there, artistic license. It does take at least 2 minutes to start working. It needs that time to do its job. It needs at least 2 minutes to do its job. So give it that time to work. It is 100% safe to use. Its only purpose is to reverse an opioid overdose. If I were to give it to myself right now, it would do absolutely nothing. It's like squirting water up my nose. If I give it to someone who was having a heart attack but exhibiting sort of other symptoms that could be perceived as an overdose, it would do nothing to them. It would just not work. It would not have any impact at all. So it is 100% safe. You could give it to someone who's pregnant or nursing. You give it to children. You can even give it to pets. So if we've had several reports of there's an encampment in Bangor in our area that they've had their pets might have had gotten exposed to their drugs, and they had to give them naloxone, and it worked on their pets. So it is 100% safe for that. We've had people who have been concerned about taking their naloxone because they've had children and they didn't want their children to get near it. It's 100% safe. They don't have to worry about their children. Also, we've had people who've been fearful of taking naloxone because they're like, I'm not near a drug user. I'm not around people who use drugs. But, I just want to remind people that number one, you never know when you might be around a drug user. And also, like, there's drugs, there's, medical diagnosis, or people who are diagnosed or experience medical situations like cancer who are heavily medicated, where you might have drugs like opioids, heavy drugs like opioids in the house, that you could certainly be exposed to drugs, and you might not be a drug user, but you might need drugs like that. Sometimes you can be recovering from a surgery, and maybe you have a glass of wine, or someone has a glass of wine, and you just don't recognize that is actually a risk factor. Alcohol and opioids together are a risk factor for overdose, and you just don't know how your body's going to react to that. So things like that are actually, that's a situation where it would not be a bad idea to have naloxone in your first aid kit or in your medicine cabinet. So those are all really reasonable reasons to have naloxone that have nothing to do with the stigma of a drug user. So I encourage everyone to have it. And the other thing is, it does all of these boxes of naloxone have expiration dates, but it will work well beyond the expiration date. And when I first started doing this, it was like, 2 years was the expiration date, and then they increased it to 3 years. And I think now the expiration date is 4 years. But there's a QR code there with lots of research that talks about naloxone working up to like 30 years and having like zero degradation of its effectiveness. So it is incredibly durable. It will work all of that time. It will work even after it's been exposed to extreme temperatures, heat, cool. So keep it. Don't throw it away. It will work after exposure to all those temperatures. It will work after all those years. So we encourage people to hold on to it. Put it in your cars, put it in your medicine cabinet and hold on to it. I mean, and obviously that's organizations can't keep medicine beyond their expiration dates. So if you have our naloxone and you need a replacement, give us a call. We will take care of that. So I'm not advising anyone to do anything that they can't do. The other thing is, you can check that out. And the other thing is when you're using naloxone, and I'll talk about this when we get to those steps as well, but when it is important to wait at least 2 minutes for naloxone to work. But then if you use it before 2 minutes, or if you give someone more, it won't make it work any faster. So I'll talk about that when we get there as well. Okay, so moving into the signs of overdose, there's a great QR code, another one. Gotta love the QR codes, it's like magic. But harmreduction.org has a lot of really great explanation about all of these signs of overdose, and will give you great great explanations. I'm seeing them in my head. So it gives you great explanations and all the information you ever need about all of these overdose signs. But there may be other signs, and there may be no signs. But the things that I like to talk about are blue, gray, purple fingernails or lips, and the slow breathing, gurgling, or wheezing. And those can be like the big triggers here in this landscape because of the sedative effect that happens with this medetomidine and the xylazine. So getting into the responding to an overdose, and we're getting into the steps now. And so talking about if you come upon someone who you think may have overdosed, check out the area, see what you can see that might, number one, give you an idea about what that person may have taken, or may have been exposed to. Maybe you can see right away that they've taken drugs and you know that it's an overdose. Also check for needles or something that, glass, so you don't like kneel down on something. But then check for a response. Shake their shoulders, rub their sternum, rub your knuckles on their up on their upper lip, try to get some kind of response. And when I first started doing this was it was either they responded or they didn't. And that was the steps that got you to the next step, to the naloxone step. But now, because of these new drugs in the landscape, it's they may not be overdosed. They may not be responding, but they also may not be overdosing. So also check some other impacts. So check some other things. Are they blue? Are their lips blue? Are their fingernails blue? Are they breathing? Are they moving? Can you feel for a heartbeat? Can you feel for breath? So check for some of those other signs before moving on to that next step. And then if not, then if they aren't, then obviously it's simply, you can move on to that next step. If they are, then maybe you're just monitoring to make sure that they're okay and they're breathing and that they don't move to an overdose, or they lose their breath, or they stop breathing. If you just absolutely cannot tell, or you just don't know, or you're fearful, or you can't stay, do what you feel most comfortable doing is, I guess, the message I'm trying to articulate. You just want to make sure you're safe. We're here to save lives, and we want to make sure that these people are safe. So do what you feel most comfortable doing. If you need to call 911. So these next two steps are on the same slide because time really is of the essence, and there's not a lot of time. And when I first started doing this, it was like you had time, but you didn't have time to waste. And now we're in this era of fentanyl. There's just really no time. So it's about acting in the most efficient way possible. So if there's two people available, then ideally one person can start the naloxone and one person can call 911. If it's just you, then you do what you feel most comfortable with in this moment. So in this situation, I've put the naloxone first and call 911. If you're feeling most comfortable to call 911 first and then do naloxone so that they can walk you through all those steps, then that's absolutely fine too. It's just whatever you feel most comfortable doing in the moment, and that's perfectly okay. So here I've got, start with the naloxone. And again, I've showed you these boxes of naloxone. One thing I want to point out for all these naloxone boxes is, so this smaller box, if you open up, you can see there's directions here. On these other boxes, they're on the back. And I tell you that because we know that sometimes everybody reacts differently in the situations in emergencies. And if you're a person who can freeze, having directions, knowing that might ground you, and you might be able to look on the box and get that motion going to see what you do next. So you'll open up that box, and inside the box there's two of these little devices, these naloxone devices. And so what you'll do is open up the device, take this little blister pack, and inside is the naloxone device. And basically it's all preloaded. You don't have to do anything other than put that right up inside their nostril and press the plunger. And when you do that, the medicine is just going to release itself up inside the nostril, into the mucous membranes, and start to do its job. And that's when it needs that at least 2 minutes, 2.5 minutes. Sometimes people will wait 3 minutes to do what it needs to do, into the, it'll work its way in through the body, into the mucous membranes, up into the brain receptors, and block those opioids on the brain receptors. So you'll call 911 right after that. If you don't have naloxone, then it's not like you're stop, and you can't do anything. You can still start which is the next step, start the rescue breathing, and still help. So you're not of no service at that point. You can still help and move on to the next step. So the next step is to give those rescue breaths. And this is especially important. And if you've had this is where, like I said before, if you've had this training before, and what you see on TV, oftentimes it's like they just give the naloxone and the person wakes up and then it's all over. And that was the training before. I think now these rescue breaths are integrated into the training because these sedatives have really created this depressive respiratory depression that's increased the overdose response. Acute respiratory depression has created this extra complicated situation for someone who has overdosed. And so rescue breaths have become even more important. So this is that next step. Give these rescue breaths. And that would be, if you've had CPR, then you know what rescue breathing is. It's just the breathing minus the chest compressions. And that's to pinch the nose, tilt the head back, and then get that seal over that person's mouth, and do those breaths, one regular size breath every 5 seconds for 2 to 3 minutes. And if you have a timer, if you have someone from 911 on the phone, you can make sure that those breaths, that you're doing that for a good 2.5 minutes, so that the naloxone has time to do its job during those 2 to 3 minutes. So a lot of times people will say to me, at this point, like, oh no, Denise, I'm not doing that. That's not for me, especially if it's someone I don't know. I'm not going to put my skin on someone else's skin for this. So that's where that's where I'm done. So we started giving out these face shields when we have the budget for them. We have these face shields. They come like this. First aid kits often will have the breathing, like squeezy breathing things. That's a official term, by the way, squeezing breathing things. And then or a mouth guard, or a mouth. That's not a mouth. That's not official. That's not an official term either, mouth guard. But the first aid kit will often have those. Sometimes people will carry these with them on their keychain or whatever. They look like this if you have the disposable ones. But if you don't have them, you can use pretty much anything as some kind of a barrier between your, basically, I'm not letting you off the hook if you don't have any of these things. You can use anything, as a barrier. You can use, in the winter, you could use a scarf or a mitten or a hat or something to use as a barrier. You can use a t-shirt, you can use a plastic bag from your lunchbox, you can use a piece of paper with a hole in it. Like, there's really anything that you can use as some kind of a barrier between your mouth and that person's mouth to be able to provide those critical rescue breaths for those 2 to 3 minutes for that person to be able to continue to keep those bodies, the vital organs alive during that time. That keeps the person free or less likely to get the brain injury for that person, and other things during those 2 to 3 minutes. So you can do that. Now, I mentioned the fentanyl causing the body muscles, wooden chests, all of those things could become a problem during the overdose response part. And this is that time. So the jaw can become locked during that process, during that time. And it's possible that because of the jaw being locked, you would not be able to open that person's mouth to provide those rescue breaths. That also does not get you off the hook for rescue breathing. You can breathe through their nose. So basically, you're just going to cover their mouth with your hand and make sure their mouth is closed. And you can do those breaths through their nose in exchange for the mouth. So you'll get a seal over their nose versus giving them on the mouth, giving the rescue breaths on the mouth. And then hopefully after one, series of rescue breaths, then the naloxone will have worked its way through that person's body. And you can give, if you have to give a second dose of naloxone and do a second round of rescue breaths, you can do it the normal way. Hopefully, maybe you have to do it the second way. I'm not sure, but that should get those rescue breaths into that person. So the next step is to check for a response. And again, this is where, like, again, in the movies, they wake right up. In the past, maybe prior to these sedatives, that person may have just woken up or started moving around. But the thing to remember is that the naloxone, these sedatives are not opioids. So the naloxone, if it's working or when it works, is reversing only the impacts or the effects of the opioid. They are not reversing the effects of the sedative. So the person may have the reversal or the overdose may have been reversed, but that person may not wake up because they're still experiencing the effects of a sedative. So awareness or consciousness cannot be the only determination for a reversal. So you have to check for some other, responses. Is their color returning? Are they breathing on their own? Is their heart beating? So are they showing other signs of life? So are they, maybe they wake right up, and that's great. That makes it so easy. But if not, check for some of those other signs of life before you give that second dose. And again, like when xylazine first started coming into Maine, it was like people were reporting that they were having to give many doses of naloxone before the person was waking up. And, just data has shown that it doesn't take that many doses of naloxone to make a person to reverse an overdose. And so that's when a lot of this came to light, is that it's because of the sedatives that they're not waking up. So just checking to make sure that they are breathing before you continue to give more doses of naloxone. If they are responding, then if they are awake and the overdose has been reversed, then you'll put them on their side in the recovery position. And that is right there. There's a picture of that recovery position right there on the slide. If they are not responding, so if they're not breathing or conscious or all of those things, then you'll give that second dose of naloxone. There's, again, 2 in the box. And if you can give it in the opposite nostril, just in case, like for some reason, something has been, something was blocked, they didn't get a good dose of it in the first nostril, whatever, you can give it in the opposite nostril, and then you can continue the rescue breaths, ideally via mouth, possibly via nose, for another 2 to 3 minutes. And then more than likely, if that either EMS will have responded by then, or hopefully the overdose will have been reversed and they will respond by then. So just to review the steps: check for response, rub your knuckles on their sternum or upper lip, shake their shoulders, shout their name, try to wake them up, check for other signs of life, and then give a dose of naloxone, even if you aren't sure if it's an overdose. So even if you don't know what they've taken, remember, it's okay to give them naloxone, even if you don't know what it is. So that's perfectly okay. We're going to assume it's an overdose. Call 911 or vice versa, and then give those rescue breaths for 2 to 3 minutes to check if that naloxone is working, if they're breathing on their own, if they're moving around, if it's been reversed, then you will put them in the recovery position, wait for EMS. If not, then you'll give that second dose of naloxone. Okay, so aftercare, basically, a lot of times people will say to me, okay, well, this is where you have to wait for that punch. People are going to come up swinging, and potentially, I guess, one thing it's really important to know is that there is no adrenaline in naloxone, so that is not going to create an adrenaline, induced situation. But trauma can create a situation where someone can be upset. And so just if you think about all these things, like naloxone can create a naloxone reversal is a brutal. So it puts someone in withdrawal, and withdrawal is very, very uncomfortable for people. When someone overdoses, they may not remember what happened. They can wake up and not remember. They don't know what happened. And if you think about someone who wakes up and people are looking at them, there might be police around, they don't have any idea what happened, it can be scary. And trauma responses can be scary, and people react differently in those situations. So trying to keep that situation as calm and safe as possible for someone, letting them know, welcome back. I'm so sorry you overdosed, you're safe. But then also being prepared for whatever could happen. And this is also the time where I usually remind people that my husband has a trauma response. And if I wake him up in after he's fallen asleep in the recliner at night, he will lash out and he could punch, and that has nothing to do with Narcan or an overdose reversal. And to put that into perspective, just be careful. I'm careful when I wake him up, and so you should be careful in any of those situations, whether it has anything to do with naloxone or not. Okay, down to the last few slides. I'm just going to talk a little bit about risk factors, and these are one of many. And again, or these are what, five of many. Harmreduction.org has lots of those risk factors as well and talks about them in depth. But I like to focus on the using alone risk factor because, again, this also goes to the accidental piece that we were talking about at the very beginning of the presentation, and that people using alone is a major risk factor. And when you think about like the rurality of states like Maine, and that if people are dying and overdosing by mistake, they're also probably using alone. And we know that in Maine, almost everyone who uses alone actually dies. And they die either because they are found too late, or when they're on the way to the hospital, or by the time they get to the hospital. And so we can actually avoid that by providing resources. We can avoid that in some way. One way we can help is by providing harm reduction. And one of these harm reduction resources is to use this hotline or help spread this option out to people. And these are hotlines or lifelines that you can share, which is the Safe Spot or Never Use Alone lifeline, which basically is just a number that you can post or provide, where if someone feels like they have to use alone, they call this number, they give them their address, someone is on the other end of the phone, and they stay on the phone while that person uses. If they don't respond after they're using, then that person on the phone will call EMS. And so it's like a simple way to help keep people alive. And again, that's what we're here to do. Last slide here is some local resources we have that discuss or that you can have access to here in Maine. Basically some local resources as far as like the recovery centers we have in our 5-county area that I work, some statewide resources, and then some national websites that I've already sort of referred to that we use. Next Distro provides resources. There's some of the QR codes that I shared. Also, they also have different resources, like if you need some things to post about intimate violence or sexual assault or anything that you can actually think of, you can find on that website. I already said the next opioiddata.org talks about some of the drug checking resources that are out there, and you can link up to where drug checking information across the country. And we know that most of the time what's happening across the country and the drugs that are in different areas of the country usually end up in Maine. So you can find out information there. And then I already shared harmreduction.org. So thank you. If you made it this far, I really, really appreciate it. If you live in Penobscot, Piscataquis, Washington, or live or work, I should say, Hancock, Aroostook Counties, and are interested in any additional training, personal training, training in your organizations or where you work, or if you want to become a distributor and provide naloxone through in your county or organization out into your communities, please give me a call or please email me at denise.smith@bangormaine.gov. We can set something up. I'm happy to do that. I look forward to doing that. Thank you so much. Talk to you soon.